Hello, my name is Hyeyoung and I will be giving a presentation about our study on understanding how to support priorities-aligned care for individuals with multiple chronic health conditions. Many individuals with multiple chronic health conditions, or MCC, manage their health at home with the everyday demands of chronic illness care, including illness work, such as physical activity, taking medications, or everyday life work, such as obligations to family or jobs, and biographical work, such as coping with the emotions around accepting and adjusting to changes in life due to illness. Patients also have complex lives outside the clinical setting where they play different roles, such as mother, son, or caregiver, that may conflict with their role as a patient. The combination of self-care tasks and different roles for individuals with MCC can be overwhelming, leading individuals with MCC to prioritize certain self-care tasks over others. Much of this daily work and prioritization by patients is not visible to healthcare providers. Improving the healthcare for individuals with MCC requires orienting care towards outcomes important to patients. Recent efforts to improve outcomes have sought to align healthcare with an individual patient's values or what an individual considers most important for well-being and health. Eliciting and sharing an individual patient's values, however, is not a routine part of healthcare. The inadequate involvement of an individual's values in care may contribute to the common discordance in priorities for care between people with MCC and their healthcare providers. Patient value elicitation and value alignment in the care setting are important because individuals with MCC and their healthcare providers often do not agree on priorities for healthcare, especially on which health conditions and treatment options to prioritize. Patients tend to prioritize symptomatic conditions over asymptomatic ones, and their personal values influence their priorities for healthcare. Although personal values are crucial to understanding patients' priorities, many of the current self-care technologies inherit the medical perspective, which aims to efficiently quantify, track, and keep the conditions under control. Such overemphasis on medical aspects can neglect people's everyday experience with conditions. Thus, Fitzpatrick, Nunes, and O'Kane suggest changing the design of self-care technologies by incorporating a holistic understanding of individuals' everyday lives, including an understanding of their social context, how they divide care with others, how they adapt to health conditions, what resources they use, and how their perspectives differ from one another. Therefore, in this study, we aim to help patients better discover, articulate, and share their priorities with healthcare providers through the conversation canvas we designed to reflect a holistic understanding of patients' everyday lives. We more broadly aim to understand the roles of visualization and facilitated conversations by human interventionists trained as social workers in the activities of reflection by individuals with multiple chronic health conditions and sharing with their healthcare providers. Our visualization tool, Conversation Canvas, was developed for mapping and exploring the connections between the individuals with MCC's personal values, self-management tasks, and health conditions. The question on the top is the conversation topic the participants chose to discuss. The participants and interventionists were able to add the relevant notes and connect them by drawing connections through edges during the first and second facilitated conversations. In this study, we recruited 13 individuals with MCC participants, 7 primary care providers of participants with MCC, and 3 caregiver participants. During the value elicitation, the interventionist used a series of conversational probes to elicit participants' values. In this first facilitated conversation, the interventionist collaboratively engaged in the conversation canvas with the participants to identify connections between values, self-management tasks, and health conditions that may be relevant to the topic that the participant chose about their care. Participants, with the help of the interventionist, selected personal values, self-care tasks, and health conditions that may be related to the topic. These were added as bubbles to an open canvas. Interventionists then used motivational interviewing techniques to help participants develop and display the connections between personal values, self-care tasks, and health conditions as they related to the participants' chosen conversation topics. The interventionist took notes throughout the conversation and then created typed summary statements. Participants then decided what to share with the provider, which was shared with the provider before the upcoming visit. Family caregivers were asked to add their reflections to the conversation after the participants have provided their perspectives. In the second facilitated conversation, the interventionists reconnected with individuals with MCC after their primary care visit or 2 months, whichever came first, to review and update items or engage in a new conversation using the conversation canvas. Lastly, we conducted post-intervention interviews with individuals, with MCC participants, and their caregivers. Interviews followed a semi-structured interview guide to capture perspectives of the individuals with MCC participants on the clinical visit and their experiences with the conversation canvas and the facilitated conversations with the interventionists. Additionally, we asked the caregivers about how the intervention affected their care and whether they had learned something new about their partners from what their partners had shared with them. The authors then analyzed the evaluation interview transcripts using inductive thematic analysis, which included open coding, focus coding, and writing up themes that emerged in the process of coding. From our analysis, we first found that the conversation with the interventionists and the visualization helped participants make sense of the interconnectedness of their values, self-management tasks, and health conditions. Also, it helped them uncover their core or base issues. Participants found the externalization of issues important and also described their interventions as a soul-searching experience. They said that collaborating with trained human interventionists on the visualization to examine aspects of life that they do not get to process daily helped them make sense of the connections between their values, self-care tasks, and health conditions, and uncover the base issue that was interconnected with their other issues and prioritize resolving the base issue. As for uncovering the base issue, participants said that the first conversations helped more than the second conversation. The second finding was that the participants felt empowered by having an acceptable medium to express their feelings with a visualization, elucidating the connections between their feelings, personal values, self-management tasks, and health conditions. Also, participants felt actively listened to by the interventionist, providing participants as much time as they need to express themselves and share all they wanted to share, capturing and summarizing what they had said, and making them feel comfortable. Individuals with MCC participants also perceived enhancements in their care during their visits. Conversation Canvas served as another layer of voice, allowing them to bring up important issues that they wanted to during their short clinical visit time. Conversation Canvas acted as an overall agenda to remind the provider of concerns and priorities that their patients wanted to discuss during the visit but normally could not. Sharing the conversation canvas with their providers created a dedicated moment for the providers to review, and they thought that this dedicated moment helped providers gain a better understanding of their priorities. From the caregiver side, they said that they were able to better understand how they could assist their partners. We also found that the intervention supported post-intervention behavioral changes. Even though some participants came into the intervention knowing what their base issue was, it wasn't until after realizing its interconnectedness with their other issues that they were more inclined to make changes to alleviate it. After the first intervention call, participants were more aware of the impact that actionable behavioral changes could have on their health conditions. This helped them take the next steps to a resolution. Participants who had started making changes after the first intervention call reflected on those changes during the second intervention call. After participants had implemented a change, they discussed how their personal values were affected by the change and how they could better honor their personal values in pursuing the change. It is also important to note that participants not only reflected on the changes they have made as a result of the intervention calls, but they also continued to reflect on their own. Lastly, we found that there are a few limitations to Conversation Canvas. First, Conversation Canvas was perceived to be useful only when it was paired with facilitation. Second, Conversation Canvas was perceived to be effective in enhancing care only if the providers review the summary of priorities. With these findings, we found potential for designs such as ours. First, our results supported design that incorporates a holistic understanding of the multiple care needs and roles in individual with MCC's everyday lives. Second, our results also suggested the potential for a design that supports iterative behavior change and reflection over time in individuals with MCC. Lastly, our results demonstrated the potential for designers to use interactive and guided visualization to help individuals managing MCC identify and work through important issues one at a time and in order of priority. We further investigated why people were making more and deeper connections between their values, self-care tasks, and health conditions compared to prior development phase studies. We associated this new finding with the use of facilitators trained in motivational interviewing, using fully functional interactive visualization, and having 2 sequential opportunities for facilitated visualization. Although human interventionists have been used in prior studies, manifestation and refinement of frames through sense-making and sequential interventions had not been attempted. We incorporated the process of iteratively refining the initial frames created in the first intervention by employing a second intervention, which followed liminal suggestion of providing ample opportunities to reshape the individuals with MCC's information needs continuously. Berry et al. Claimed that reflection on values and health in the future allows people with MCC to clarify their healthcare priorities and articulate those with their providers, which was also shown in our study. With the design implications and potentials we have shown with our study, we hope to support future work on supporting priorities-aligned self-management and care planning. Thank you for listening, and here are references.